Dr. Paul, it's wonderful to have you on the podcast. I've been really excited to interview you. I think we have a ton to talk about today, and you're one of the few metabolic health practitioners that I know focuses on all of the things that I do with my students and patients. So, very excited for this interview. I'm hoping that today we can kind of go through your backstory a little bit and how you came to be a metabolic health practitioner. And then we'll talk a lot about continuous glucose monitors today because you wrote a whole book about that, which is fantastic. And then I know there's people who are so interested in learning about your take on the GLP-1 medications such as Wegovy and Ozempic, and we can get a little bit into those as well, how you are utilizing those and using those in your practice. So we have a
Okay.
lot to go over. So why don't you, I would love to start with, I know you were an ER doctor for like 30 years and now you're
Right.
specializing in metabolic health. So tell us how you got, like how that came to be and why you're so interested in metabolic health.
Well, as you mentioned, my background's in emergency medicine. And what gets all the press in the emergency department is the gunshot wounds and the overdoses and the multiple traumas. But really, what emergency physicians do day in and day out, all day long, is take care of problems related to vascular issues, that is, blood vessel issues, or the musculoskeletal issues related to excess weight, and also the metabolic health issues related to excess weight. So, realizing that all day long, I'm seeing kidney failure related to diabetes and strokes and heart attacks and peripheral vascular disease. And those are all the result of vascular inflammation. And I think we probably are one mind, we'll get into this, is that I think that's a lot more related in this country to insulin resistance and high blood sugars than it is cholesterol, which we have been focused on for the last 50 years. And so after being in the emergency department for that period of time, I realized that I wanted to, rather than be reactive, be proactive and get out in front of those issues. So I opened a metabolic health practice about 7 years ago with a focus not that different from what you do, Shanna, which is primarily focusing on insulin resistance and how to reverse insulin resistance to achieve not only weight loss, but metabolic health.
Well, we're glad that you made the transition. That is very, very different from seeing somebody so acutely, just for a
Yeah.
few hours to really just following them, down the path of actually reversing health issues and overcoming them because they can be overcome. A lot of times people think they're diagnosed with diabetes or fatty liver or um, any kind of metabolic disease and they're told it's progressive and lifelong and that they'll just have to take medications and keep stacking the medications. So yeah, we definitely need more doctors out there like you. So we're glad you made the transition. So what do you think it is that I think the latest stats are 93% of American adults have some sort of metabolic disease or dysfunction or some degree of insulin resistance. What do you see as being the primary driver of that? I mean, we talk a lot on the podcast, but what's your take on why we are in such a metabolic crisis?
Yeah, so my belief is that it goes back to the food pyramid, the introduction of the food pyramid in the early 1970s. And we were told that fat was bad, again, the cholesterol issue that we just talked about, and that we had to stay away from fat. And overnight, based on, a recommendation of the United States Department of Agriculture, based on which I think was bad science. I'm sure you've talked about Ansel Keys and all that background information on your podcasts. We were told that we needed to avoid fat and embrace carbs. So almost overnight, our diet went from the traditional American diet, which was 25% carbs, 50% fat, 25% protein, and the fat and the carbs got switched. And now we were 25% fat and 50% carbs and 25% protein. And I believe if you look at the curves at that point in terms of the demographics of what happened related to obesity, that's when the curve takes off. That's when we began gravitating toward being an obese country. And then 10 years after that, the diabetes took off, just as you would expect. You get overweight, you increase your fat stores, and then you become progressively insulin resistant and eventually pre-diabetic and then diabetic. And then, 20 and 30 years later, the onslaught of the vascular issues associated with that. And so, really, I think there's really no argument about that. You look at the 30s and 40s, you look at old movies or photographs, you don't see the amount of obesity that you see now. And so, we were led down this path, a lot of confluence of issues with, fat being bad, and all of a sudden there was a drug to treat cholesterol. So we need to, get behind that. And then, incentives of, and again, I'm not going to be a conspiracy theorist. I understand people are in business to make money, but the food processing industry jumped right on board with seed oils and refined grains and sugar, because that was a profitable model. And so, the American population has been led down this path of high carb, and it's not been good for us. It's resulted in many of the problems we have today.
Yeah, and I often think about that as that's in my career as a dietitian. I was conventionally trained, and I've been in practice for 20, almost 24 years. And I often think about like where the disconnect is, because I remember teaching as, in my first job, we had a little booklet of people who would come in and were overweight, and we'd go through the food guide pyramid with them. And I remember suggesting like no more than 30 to 40 grams of fat for most people over the course of the day. And, eating at least 5 to 6 servings of whole grains. But then I go back to the science that I learned in my undergrad, and it really just doesn't make any sense. So it's like the disconnect becomes, or I think, it just comes from the food system and the overall, food companies that are now, trying in charge of a lot of the education that dietitians receive. Because I'm like, we learned the right physiology. I just don't know how it got to the point of us teaching such terrible concepts. And it goes back to the food guide pyramid, and then the My Plate wasn't really any better. And such a strong focus on carbs and getting away from natural fats and proteins for sure. But I know, so let's talk about the cholesterol issue just a little bit, and then we'll move on to using continuous glucose monitors, because I would love to dive into that. But can you tell us about the relationship between insulin resistance and cholesterol? Because we're just stuck, and then maybe insulin resistance and blood pressure, because we're so stuck in this, salt causes blood pressure issues, fat and saturated fat and cholesterol that you eat cause the cholesterol issues. So can you clear that up a little bit for us? We've talked about it on the podcast, but I just feel like it's worth noting and reviewing again.
Yeah. So first of all, for my patient population, and they're selected to be people generally that are overweight or have metabolic health problems. I believe insulin resistance is a much, much greater issue than cholesterol. And insulin resistance, of course, can contribute to higher cholesterol, but I believe insulin resistance really is the underlying problem and the problem that needs to be addressed. I have patients that go see their mainstream doc, and we'll talk maybe a little bit about mainstream medicine and how you mentioned mainstream nutritional approaches. We'll talk about how mainstream medicine maybe approaches this issue, which isn't helpful either. But there's this huge focus when people go to see their doctor on their cholesterol level. Your blood sugar is 103, your fasting blood sugar is 103. And we'll just kind of keep an eye on that. But your cholesterol is 201, and boy, we really need to go after
Yeah.
that. And so I think the primary reason for vascular inflammation for the majority of people that have problems is insulin resistance and the inflammation that blood glucose causes. A hemoglobin A1C results from blood glucose attaching to hemoglobin. That's how you get that percentage, that number, whether it's 5.7 or 6.3 or whatever. But that glucose is also attaching to the lining of your arteries, and it's attaching to your cartilage as well, causing inflammation. And so I think for the majority of people, that inflammatory focus is a much bigger issue than cholesterol. And I think we're getting more and more information these days about cholesterol and the degree to which it's harmful. And I don't know, have you got in your previous program, have you talked about cholesterol subunits at all and the different types of cholesterol as opposed to just cholesterol as a monolithic problem in and of itself?
Yes, yes, we have.
Okay, so again, I think people, if they have a little bit of a high cholesterol, they need to be knowing what their subfractions are of cholesterol. Basically that comes down to the LDL type, whether it's the small, more inflammatory ping pong ball, if you will, type versus the large fluffy type of LDL. Because a mildly elevated cholesterol, it really can often not be any significant issue at all. And I'm not completely opposed to looking at cholesterol and, people being on statins. I think that has its place. I referred people to a lipidologist previously, but again, I think the main event is insulin resistance, both in terms of metabolic health and weight gain.
Yeah. And I know on this podcast, and when I'm working with students and they show me their lipid panel, I'm always keen in on the triglycerides and the HDL and looking at that ratio, because as insulin resistance progresses, so does an increase in the triglycerides. And so we look at the triglyceride to HDL ratio, and I always look at that to be less than 1.5. And if it's not, I'm like, you have some work, you have some work to do
Right. Yeah.
metabolically. And yeah, it's like
Well,
they use that 200 mark as cholesterol. And my 20-year-old daughter just got some labs done a few weeks ago, and I think her cholesterol came back like 207, but her HDL was like in the 80s, and her triglycerides
good.
are like 40 in 50 maybe. I'm like, don't you ever let anybody tell you that you need to worry about your total cholesterol, because what is actually important looks stellar. So
Yeah. Is she low carb with that low
yeah,
triglyceride?
she is.
Yeah.
Yeah.
So one thing that has amazed me during my practice that I don't know if people have a lot of insight into is the way triglycerides plummet when you go on a low carb diet. Because, triglycerides are formed from the conversion of blood glucose to fat in the liver. And if you lower your blood glucose, which of course is going to help reverse your insulin resistance, your triglycerides plummet. I'm still surprised at that sometimes with new patients that they'll come in and they'll have an initial triglyceride at 240 and they'll go low carb for 8 weeks and all of a sudden their triglyceride will be 65 or something like that. So I think that's a big piece of the puzzle as well.
Absolutely. And it's kind of like an inverse relationship. You'd almost expect the opposite, but it's really, you see it time and time again. And yeah, when you see it on paper, that's that's really helpful. So let's talk about the low carb, because I know there's not really like a definition out there, and it's hard for people. Like in my practice, I'm typically suggesting for low carb somewhere between like 25 and 100 grams of carbohydrate, depending
Yeah,
on their disease status, what their goals are, how active they
right.
are. If are they just doing this more for longevity and maintenance, or are they actually trying to reverse a disease process? So when and we kind of throw that low carb term around, but there's really not a definition for it. What are you using with your patients when you're putting them on I hate to say like low carb diet, but low carb approach, we could say that.
Right. Good. Thank you. Yeah. So, given the typical American diet is what, 250, 300
Oh
grams of
yeah,
carbs?
three to four
Yeah.
hundred usually. Yeah.
Yeah. Or more. My initial goal for people is generally around 50. And I don't know what your experience is, but mine is that if you try and lower it slowly and incrementally over a period of time, it's a painful process. People don't make gains. And so we usually rip the Band-Aid off and some people I'll go 70, but most people I direct to 50 grams a day. And then we usually settle out 35 to 50 or so long term. But I just feel and people don't seem really not to have problems once they understand the concept. And we'll talk about that with CGM curves as well. Once they understand the concept, they realize getting to 50 is very doable. I have a few people go keto, but actually, quite honestly, not a lot. I'm not against keto. I think if people want to do that, that's great. All kinds of information coming out related to ketogenic diets and brain health and all that type of stuff these days. But most of my patients are low carb, and generally the target is 35-ish or up to 50 or so.
Okay. Yeah, that's very similar to where my students and patients are floating to. And again, it depends if they're trying to reverse a disease, but yeah, if you're trying to reverse metabolic disease going over 50, it's going to be a lot a lot more challenging. And I know I don't really track mine every single day, but I kind of sit in that 50 to 75, maybe 100 tops on days that I might be flexing some high carb, but I don't have disease to reverse. I don't have weight to lose. I'm metabolically healthy and I'm pretty active. So I like to hear that coming from you though. So let's talk about the continuous glucose monitors. Like we mentioned, you wrote an entire book, and I want to make sure I get the correct title, The Continuous Glucose Monitoring Revolution. And I have often said on this podcast, like if I feel like if everyone could slap a CGM on even for 2 weeks, a lot of this metabolic health crisis and mess would go away. And if we could, get the monitoring even longer, so you could actually start to test some foods out and
Yeah,
look at what's really affecting yours, we would be in such a better place. But of
right.
course, that's not what's happening right now. But tell us why, just tell us a little bit about the basis of your book, like how you started using the CGMs with your patients and what you're seeing when they're using those.
Yeah, so the focus of my practice is primarily non-diabetics with metabolic health issues and or pre-diabetics. I have some diabetics and we use the CGMs to help lower their medication requirements. But most of the time it's used to improve metabolic health, weight loss, and to reverse pre-diabetes completely. And your comment is entirely appropriate. Slap a CGM on people. So the result of that often is, as my patients put it, once I see those graphs, once I see those spikes, I can't unsee it. So their doctor may have been talking to them for years, or their nutritionist about, we need to limit your carbs more, we need to watch that. But once they see those graphs, it literally can be life changing, because then they understand for the first time what's going on with their blood glucose physiology, what's going on with their insulin resistance, and they change their habits. And it's really a lifestyle change. And you know how low carb is. It's like, yeah, it might be a challenge at first, but over a period of months to years, you get to the point where you just don't think about eating certain foods again. I mean, you know what they're going to do to you. And a CGM is very, very important in that regard. So the process I use is people come in, and the first thing I do is what I call a CGM trial, like I describe in the book, where we put a CGM on them. And I like your term, slap a CGM on them. That's great. That's great, because
Basically what you're doing, right?
yeah, that's basically what you're doing. And I tell them to wear it for 2 weeks, and I ask them not to change their diet. Okay, let's gather baseline data for 2 weeks, because I want them to see those curves go up, and I want them to understand if they have, pizza or even pasta or a baked potato, what is going on. So we do that for 2 weeks, and we'll get back to this, but also I measure insulin levels during that period of time. We do a fasting insulin level, and we calculate level of insulin resistance. And that really kind of gives us our baseline data over a period of time that we then can act on. And have you talked much about fasting insulin levels? You
Yes, we
probably
have. And I was just going to ask you if for looking at insulin resistance, the severity, if you're using the HOMA IR score, or what are you using for that?
Yes,
Okay.
exactly. So HOMI, to explain it to people, is you get a fasting insulin level and you get a simultaneous blood glucose level. And there's a relationship between those two. Because if your insulin level is high, it should be pushing that blood glucose down because insulin is the key in the lock of your organs. And I always use muscles as an example of organs, basically to force that blood glucose into your organs to use as energy. But if your blood glucose is somewhat high and your insulin level is high, that means your pancreas is continuing to kick out insulin, trying to force that blood glucose into those organs, but the organs aren't listening. That's what insulin resistance is. The organs are saying, insulin, I'm not going to listen to you anymore. And so that means you have insulin resistance. And then, of course, what's happening is that extra, as we talked about with triglycerides, that extra blood glucose is going to the liver and get converted to fat. I thought about when we were talking about triglycerides, that's also the high blood glucose is what causes fatty liver disease. So fatty liver disease is a misnomer. Everybody thinks, well, I need to stay away from fat because it causes fatty liver disease. When fatty liver disease, the fat is not causing your fatty liver disease. High blood glucose being converted to fat in the liver is causing your.
Hmm.
So that's the approach I take in the first couple of weeks, a diagnostic approach using a CGM without alteration of diet and then determining level of insulin resistance. And, we do check lipids and vitamin D's and other things. I don't have as much a hormonal focus as I think, you do in your coaching of and working with people, advising to people, but we focus on those two things and we use that as baseline data then to put a program together.
Yeah. And I think it is important to look at, like, not change your diet at all, because it's like whenever I wear a CGM, you are more careful because you don't want to you see it starting to climb. And I've told people on the podcast many times, like, cherries are my favorite fruit, but if I even have 6 of them, I just watch that
Yeah.
blood sugar start climbing. I'm like, oh, I gotta go for a walk. So I gotta get out. But it is like, I think before you make any changes at all, it is really helpful to just wear it and see. And I often have people ask me, well, I'm monitoring my blood sugar and poking my finger a couple of times, like when I get up and a couple hours after I eat. And I'm like, well, that's helpful and it'll give you some information, but it's such just a little snippet and you're not going to catch the curve of when you're eating. And if you're having protein and fat with your carbohydrates, you're probably really not going to catch the curve. And then the little bumps, the little
Right.
spikes that are possibly happening later on. So yeah, if you haven't worn a continuous glucose monitor, I always, like, when I have people come into my program, they're optional just because some people can get them covered by insurance. So I don't want everybody to
Right.
have to pay for them if
Yeah.
they're getting them covered. But I think it's like that data. A lot of times people will ask me, should I get a CGM or should I get, some other type of, like, we talk about the Lumen device in my course and
Right.
a couple of other things, like CGM all the way. Not
Yeah.
I don't love the Lumen, but it just gives you so much data. And what I have people really keying on too is, like, we have the spikes, but how are you feeling during blood sugar spikes, but how are you feeling during the crashes that are then
Right.
following the blood sugar spikes? Because that's when you're really going to feel like crap. And
Right.
like that's what we really want to key in on. And how are you feeling as that blood sugar is starting to come down? Yeah.
Right. And the physiology there is you spike that blood sugar and then your insulin spikes, but insulin is often a little bit late to the party.
Mhm.
And then it makes you crash, and now there's all this, data coming out
Mhm.
related to how that can affect brain health as well. And there's no question there's a relationship between low carb or keto and brain health because, keto diets were originally used for the treatment of pediatric seizures.
Yeah.
So there's no question that there's a relationship there. And it begins to get to the heart of the issue of people really understanding what a carb is. And I know you probably run into people that are diabetic and they really don't understand how carbohydrates impact their blood sugar. Because we all know sugar is bad for us. But we don't necessarily all understand that when you eat a carb, it instantly becomes blood glucose in your system. And I don't know if you've seen the infographics done by David Unwin, who is a doc over in Britain. And he'll say, okay, a cup of pasta equals this many teaspoons of sugar,
Mhm.
or a cup of rice equals this many teaspoons of sugar. And that's the way people should think about
Yeah.
carbs, I believe. That it's instantly converted to blood glucose in your system, and it's going to result in a rise in your insulin, and eventually, potentially the cause of insulin resistance. And once you begin to understand that, and a CGM is a great tool to help you do that, then you can begin limiting that intake. And, we use the CGMs initially diagnostic, as we talked about, but then they can be used to guide diet long term as well.
Mhm. Yeah, and just to reiterate your point about fatty liver being a problem of too many carbohydrates, too much grains, too much sugar. And they think I have fatty liver, I have to cut back on fat. I can't eat any fat at all. And then the fat that they're eating is the inflammatory fat in the seed oils. So
Right.
that is a very important point to just reiterate that. And a lot of my listeners know that my mom developed cancer due to decades of fatty liver that was untreated, and she was just told to watch, and it progressed to cirrhosis and cancer. And unfortunately, like, she was never properly told what to do, and she was not a drinker. A lot of times people think they're only going to get
Right.
fatty liver
Yeah.
because they drink a lot. And when I first started practicing, I didn't see a lot of fatty liver unless it was alcoholic, but now it's like it's mostly non-alcoholic. And the very disturbing part of fatty liver is that children, I forget what the percentage is up to, but it's a percentage that's very disturbing, that kids
Right.
are developing fatty liver primarily from fructose that they're drinking and juice and soda. Um,
Yeah.
yeah, so it's just huge problem, but the CGM is a good first step. So after those first initial 2 weeks, then what are you then kind of intervening, or are they like, where do they go
Yes.
from there? Yeah, okay.
Yeah, so we get the baseline data, we calculate the HOMA IR, we
Okay.
understand the level of insulin resistance, we have 2 weeks worth of CGM data, and then we put a plan together. And there's three primary legs of that stool, which is the low carb approach, intermittent fasting, which I think is, very healthy for nearly everyone. And then the third component is strength training, which also decreases insulin resistance as well. So those are the three primary approaches. When we talk about intermittent fasting, again, from an ancestral standpoint, that's what we did, for, tens of thousands of years. When we were cavemen and the hunt was great, we, ate woolly mastodon meat. And then when the hunt was not good, we would fast for 2 weeks. And the same thing once the agricultural revolution occurred. When we had a good year, there was plenty of food, but there were years where we had to fast. So I think fasting really is a natural state. Now, I have patients that come to me and they've never fasted before. And so what are we talking about there? Well, let's start. If you've never fasted really any significant degree, I have people that have never fasted more than 8 hours because, we're told that we need to eat 6 meals a day. You know that story.
Mhm.
So we start with 10 or 12 hours, but most of my patients, I generally move on to a 14 or 16-hour daily fast. If they want to do occasional longer fasts, a 24-hour fast once in a while, I'm a proponent of that as well. But you don't need to do days of fasting. Just fast overnight for a long overnight, 14, 16, 16, 8 if you choose, maybe an OMAD, a 1 meal a day approach if you choose to do that. But that's the second leg of the stool, because nothing lowers insulin resistance other than a low carb diet better than fast.
Yes. Oh, that you're speaking my language. I always say the two most potent strategies to reverse insulin resistance are fasting protocols, not overdoing them, fasting protocols and low carb, because that's what's going to suppress your insulin levels. So sometimes people don't like to hear that. And like you said, I was one of those people. I would never go fast more than 8 or 10 hours. Like I ate healthy food or I thought I was eating healthy food, but I would start eating at 5 or 6 o'clock in the morning before my workout, and oftentimes would still have a snack after dinner at 7, 8 o'clock, and that was not a lot of fasting hours. So
Yeah.
even if it's healthy food, it's still problematic, especially if you have insulin resistance. So yeah, we start to move away from eating so often and getting that big chunk of fasting time in, and then working on the in between meals from there for sure.
Yeah. Well,
Uh,
and we've been taught breakfast is the most important meal of the day. You
oh
got to get up
yes.
and eat your cereal, right? And then you need to be eating at least 6 times a day.
Yes.
So
For
that
energy.
is a,
Yeah.
yeah, it's a model for selling food. It's not a model for health.
Yes,
Yeah.
that's a great way to put it. Definitely. Yeah, and the big food does not want us fasting or learning about metabolic health, because we know that all of the ultra processed foods, what's really putting us over the edge as far as spiking our insulin and giving us blood sugar spikes. So yeah, and I love how in your book you say like the CGM can work for you when everything else has failed, because you are seeing what's going on in your body in real time, and there's no other process that can give you such immediate feedback with your blood glucose. So you said the three legs of stool. We talk a ton about fasting protocols and low carb, but you also touched on strength training, and we do talk about strength training on the podcast also. But can you go into that leg a little bit more in depth and just tell us why, especially as women and especially as we age, we really just need to get some strength training into our daily route, or not even daily, but our weekly routine.
Yeah, yeah, yeah. Strength training, I think, is huge. So I'm not completely opposed to cardiovascular fitness. I'm saying that tongue in cheek, of
Right,
course.
right.
I think people should follow the American Heart Association guidelines related to cardiovascular fitness, but that can be as simple as getting your heart rate to 65% of your max for 150 minutes a week, or what I prefer is 80 to 85% of your maximum heart rate for 75 minutes a week. So think about that. You can spend 75 minutes a week, okay, an hour and 15 minutes, and get all your cardiovascular fitness in according to the experts in the field. What does that mean? Well, that means you have more time for your strength training, which really should be the focus. And the reason strength training is important, especially for people with insulin resistance, is that if you increase the size of your muscle mass, the amount of muscle you have, you're increasing both the quality and the receptivity of the insulin receptors on those muscles. And they are soaking up more insulin, and they are soaking up more blood glucose, and they are helping you reverse your insulin resistance and your fatty liver disease and your visceral fat. So strength training is a huge part of this. You mentioned very important for all of us. So, as you probably know the stats, is we age after age 30 or so, we're losing 7% of our muscle mass every decade. Some people say more than that. So this affects both men and women. So you've got to be strength training as you get older. And of course, for women, it's a huge deal because of the osteoporosis issue. Men get osteoporosis as well. Women, because of the hormonal changes, have a tendency to have a bigger problem with that. But the physiology simply is that if you increase your muscle mass and you're doing strength training, you're putting more stress on your skeletal structure. The skeletal structure responds by laying down more calcium. It has to respond to that. It's getting stressed. A little bit of, if it doesn't kill you, it'll make you stronger. A little bit of that can be true at times in terms of stressing your skeletal system. And then it gets stronger with more calcium. So this is a huge component of both reversing insulin resistance and preventing osteoporosis as you get older.
Yeah, couldn't agree more. And yes, we talk a lot about that and the need for more protein as you get older.
Oh, absolutely. Yeah.
And for
Yeah.
many reasons, I mean, we're losing the muscle mass, our stomach acid is not as much as it used to be, so we can digest it as well. It's not absorbed and utilized. But yeah, so a lot of times women, we're not eating enough protein as it is. And then as we age, we think we need less and less. But
Yeah,
yeah.
so let's talk about that in terms. So what I tell my patients is, yeah, and this is strange. We'll get into the good fat, bad fat thing maybe, but it's like I tell my patients I want you to limit your carbs to this amount, okay? And I want you to get at least this much protein in. And I don't say it this way, but I'm kind of thinking I don't really care about your fat. Now, that's not completely true. It's like, okay, you got to avoid the seed oils. You need really to avoid any fast food which is cooked in seed oils, but I just put a much greater emphasis on the lower amount of carbs and the higher amount of protein. And most of my patients tell me getting adequate protein is the harder of the two.
Mhm.
That they get really honed in on managing their carbs and limiting their carbs, but pushing that protein can sometimes be tough.
Yeah, yeah. And I'm giving women, just as a general rule, like 100 grams of protein a
Yeah,
day target, men
yeah,
more like 125 to 150, depending on their mass. But yeah, women are like, how? And especially if we're trying to only eat 2 meals a day and limit
yeah.
our times that we're eating, they're like, how do you do that? And so that's a big focus of mine is just showing them how to put together 50-gram per meal plates, 50 grams of
Right,
protein per meal, because you really have to be mindful of it. But what happens then is then they're full and they're able to go 5, 6 hours without eating and thinking about food because their appetites are suppressed. And yeah, I'm the same with fat. I don't give people like a clear-cut guideline. I'm like, just make sure you're getting a couple of natural sources in. And they want to know, like, well, what gram, like how many grams? I'm like, well, it really depends on your carbohydrate intake, and there's just more variables with fat. So I try to just say, let's just focus on eating a couple of natural fats that aren't processed, and then we can kind of tweak it from there. Because I
right. Yeah.
agree, that's a little bit more challenging to give people a clear-cut guideline for.
Right. Right. And so I do try and keep it simple. Avoid the seed oils, focus on omega-3s. You can educate yourself about that. Avoid fast food. We come from a generation where we were told butter is bad and you need to have margarine. So, you got to get out of that mindset. So,
Yes,
yeah.
yes. Oh, yeah. We had tubs of Brummel and Brown and all kinds of. I remember dipping like saltine crackers into tubs of and like animal cookies into tubs of Brummel and Brown, like eating that as a snack. Like, no wonder I destroyed my metabolic health. But well, let's turn to a different topic, but one that's hot right now, and I know one that you're very knowledgeable about, and that is the GLP-1 agonist medications that are very, very popular, and how you're using those in your practice. And I've had many experts on the podcast talking about the GLP-1s, the semaglutides, the tirzepatides, and people having a lot of success with them. But you and I were talking a little bit before we started recording about the topic of just making sure people are monitored correctly, dosed correctly, and that they're implementing all of the things that we've talked about up to this point so that they can be more successful. So how are you using the GLP-1s in your practice? And yeah, let's just start with that question.
So, everybody in Hollywood is on these medications. So the genie is out of the bottle on this, and people are going to use these medications. So my goal is to guide people in using them the right way. And I believe the right way is limited doses, low doses, not high doses. Don't go to the highest dose. Keep the dose at a moderate dose and plan on using it for a limited period of time. Because if people come into my office and they want to use these medications, first of all, we talk about the foundation, which is what we've talked about for the last 45 minutes.
Yep.
Um, And then we talk about what is the plan. It's like the Stephen Covey book from 25 years ago. Begin with the end in mind. And the end in mind is avoiding lifelong dependence on these medications. Now, the pharmaceutical companies would like you to go that direction. This is a chronic disease. We're just going to go ahead and treat it for a lifetime, like you would, for example, high blood pressure or whatever. But I think people should begin with the end in mind for a variety of reasons because of the negative effects of these medications, and they do have some negative effects, and the cost considerations of these medications that you need to begin with the end in mind. And the end in mind is, preferably use for months, not years, and use at lower doses. So I use it I use the medications in two instances usually. The primary instance I use them in is when people have come in and they've done everything I've asked them to do, like we have just talked about, and they hit a stall. And this is usually, middle-aged and older women because of the hormonal issues. And then we look at dipping our toe in the water of utilizing these medications prudently. We'll talk about exactly what that looks like in terms of dosages, et cetera. And then I do, and maybe, I've had more angst about this, but then I also see people that come hell or high water, they're going to use these medications no matter what. They're seeking somebody to prescribe these medications. And I'd rather have them in my universe, my type of program, than going to the internet and doing a 15-minute visit and being prescribed medicine for the next 6 months without any associated plan to get off the medications or to address their metabolic health issues. So those are the two instances which I have a tendency to use them in. But again, we begin with the end in mind at lower doses and with a plan for limited periods of use.
I like that because otherwise like you said, they're supposed to be utilized, or how they're prescribed is lifelong. And number one, people get sick of not wanting to eat and not having fun with a lot of times if they're nauseous or not feeling well and they're having a lot of side effects. And number two, the insurance coverage. And maybe even if you've had insurance coverage for 6 months or a year, at any given moment that can be pulled out from underneath you, and now you're looking at $1,000 plus for the medications. Because I agree, I'm not like completely pro or completely against. I think that they have their place, and it's highly variable from person to person. And I do believe you should exhaust your lifestyle tools first and really give that a go. But there does come a time where they are very helpful for a certain population. So do you have a preference over the semaglutide versus the tirzepatide?
Well,
So one is the Ozempic and the Wegovy would be the
right.
semaglutide, the tirzepatide, the Mounjaro, or the Zepbound, which is really new. I don't
Yeah.
honestly know really anybody who's been on the Zepbound yet, but and I'm the prescription and the how you're prescribing them is completely different based on what you're dealing with yourself. But do you have a preference of one over the other?
Well, so first of all, people are a little bit focused on the tirzepatide because the weight loss is supposed to be a little bit greater with it, maybe up to 18% as opposed to 15%. But what I've seen and what I believe is there's no significant difference between the two. If you're doing the other things you're supposed to be doing anyways, it just does not make that big a difference. And yeah, so to go through kind of the differentiation of them. Ozempic is for diabetics. The weight loss drug, exact same medication is Wegovy, and that is semaglutide, which is available in a generic compounded form as well, which can be much less expensive. And I do use some of that. I've had hundreds of patients that have not had issues with it. So that's primarily what we use. And the insurance coverage is variable now. I'm seeing companies that are incrementally adding coverage. But I've also seen companies that are taking away coverage because they saw the impact on their insurance costs related to this. So, these are going to be good medicines long term. I think probably will end up being the most prescribed medications in the history of the world because the drug companies are going back and saying, oh, this is good for fatty liver disease. And this is good for cardiovascular disease, and this is good for sleep apnea. So I think the genie is out of the bottle. They're going to be prescribed. So it's really incumbent upon us to use them prudently. And then the other medication is Monjuro for diabetics. Can only get it if you're diabetic. The doctor's got to sign a prior authorization saying you're diabetic. Zepbound just out in the last 2 months is the weight loss form. Again, the exact same medicines, Monjuro and Zepbound, and then tirzepatide is the compounded generic that's available. So the way I approach the use of this, if people, I'm going to give a little bit of background first. So the reason these medications became popular is they originally were prescribed to diabetics, but the drug companies noted that people lost weight without bottoming out their blood sugar. So basically, it controls blood sugar in a limited range without causing hypoglycemia. So they went back and did studies just for weight loss, and lo and behold, people lost weight without the complication of hypoglycemia, and that's when they became marketed for weight loss. They have three mechanisms of action. One is it slows gastric emptying, so it narrows that pyloric valve, the valve between the stomach and the intestine, so your stomach stays fuller for a longer period of time. And then it lowers blood sugar. And when we lower blood sugar, you burn more fat, just the same mechanism as reducing insulin resistance. And then the third is that there's a direct effect on the brain, on the hypothalamus. So it addresses the hunger center. And then the way they're prescribed, if people aren't familiar, is a once weekly injection. So you start at a low dose, you use the same dose for 4 weeks. There are some side effects, mostly nausea I've seen with my patients. But what happens is you accommodate after a few weeks. So you get nausea maybe for the first week or two. By week 3 or 4, it goes away. Then you bump the dose to the next higher dose. And you can continue that escalation over a period of many months. Now, my preference, as I mentioned, was to use lower doses. So I'll escalate, for example, maybe to 1.5 milligrams as opposed to the maximal dose with semaglutide to 2.4, and we'll keep people at that level while we're doing these other things, because we're beginning with the end in mind, which is our goal is to get you titrated down and off this medication once you've made all these lifestyle changes, and that's going to be easier to do if we don't go to real high doses right from the beginning.
I love that approach. So are the compounded ones, are you doing in even lower doses or
Yeah,
okay.
Yeah, and so I actually have people that I've had on as low a stable dose for a period of months of 0.5 milligrams. So, again, the equivalent we could go up to 2.4. But people are getting, some good hunger suppression at lower doses. And, my perspective is you're just creating more dependence the higher you go. And it's going to be harder to reverse that. The downsides of these medications are weight regain when you go off. Up to 70% of the weight that you lost can be regained if you don't put these lifestyle changes in place. And then the other huge issue that I know you're aware of is the muscle mass loss. When you're losing weight, you're losing muscle mass as well. And one thing I would advocate for anybody that considers these medications, you got to be strength training and you got to be getting your protein if you choose to use these medications, because if you aren't, you're accelerating your muscle mass loss as you age, and you're accelerating that risk of osteoporosis.
Yeah, and that is my primary concern, is if you're not implementing the correct lifestyle changes along with the medications, are you actually worsening your body composition and maybe like have a higher fat percentage and lower muscle or lower lean tissue, even though you're losing weight? And that's the last thing we want. When you want to lose weight, we want to lose I mean, we're going to lose some lean tissue. It doesn't
Yeah,
necessarily mean it's muscle mass, it's just lean tissue. But our main
yeah,
goal is to lose mostly body fat and really help that body
yeah,
position along. So yeah,
yeah,
and the lifestyle, it's got to be foundational
yeah.
for success for
Yeah.
sure.
Hey,
Yep.
I'm going to throw a little curveball in here and mention something else that's
Sure.
interesting. So in my emergency medicine background, I've had the opportunity to take care of a number of people that are alcohol dependent as well. And something real interesting is happening with these medications. And I see this routinely. Have you talked about this before
Not on the
with
podcast, but I've seen
involved?
the literature and how
Yeah,
it's been helping with
yeah.
alcoholism. Yeah.
So I have patients that I have patients that are drinking more than they want to drink, and they come back and they just say, as they're getting this hunger suppression, their desire for alcohol, it goes down significantly as well. And I've had patients that really just, they were social occasional drinkers and they've stopped drinking altogether. They just have no desire, maybe even get a little bit of nausea when they're on these medications associated with their alcohol use. And I do believe we haven't had a good medication for alcohol use reduction in many, many years. I've used naltrexone, another medication with patients, which I think can be helpful. Um, but I think these medications, I would be surprised if they do not eventually get approved for alcohol use reduction as well. That's coming. The studies just need to be done. The tricky part right now is that you really can't prescribe these medications to people that have a low BMI that might have an alcohol problem.
Sure.
So, I guess, the perfect patient maybe for these medications would be a person that's drinking a little bit more than they want to and is overweight. But I think, from what I'm seeing clinically and from what I'm reading in the studies, that this, is going to be a very significant for the treatment of alcohol use disorder as well.
Yeah, it's interesting and really any kind of addictive issue
Yeah, yeah,
help
yeah,
with this. So it is. It definitely, like you said, it has its time and place. It's just we want it to be used, prescribed, and followed correctly, if that's the route that you so choose. And like you said, to successfully be able to come off, because we don't want your end goal to be on these medications forever. You probably won't be able to
yeah,
afford it anyway. So, well, as
yeah.
we close out, this has been a really great conversation, and learned a ton and gone over a lot of information. But where can people find you? Tell us what states you're able to work with
Okay.
people in, and then point us toward your other content as well.
Okay, thank you very much. So I'm licensed in Ohio, Indiana, Florida, and Arizona. The majority of my practice, probably over 90% of my practice now, is telemedicine. It's really a great approach for this type of practice because we can accomplish everything that needs to be done in a telemedicine session, basically a Zoom like this. And then also the book is on Amazon, The Continuous Glucose Monitor Revolution for Non-Diabetics. And it's the highest rated book on CGMs on Amazon right now, I'm proud to say. And then my practice website is metabolicmds.com, the word metabolic, and then mds.com. And then you can find me on Twitter. Usually the handle that I use is Dr. Colo, DRKOLO. And you'll find me on Twitter, on TikTok, on Instagram, and on LinkedIn using some permutation of that handle.
Awesome. We'll link all of that in the show notes. And we are so happy about the work that you're doing in your book. I mean, if anybody wants to learn about CGMs, this is a fabulous book. I should, before we close out, how are you using, how are you getting at, you can prescribe them, but how do you have a way for people to access CGMs if they're not working through a physician? I know I work with a
Yeah.
company. I'm curious if you do too.
Yeah, so basically it's working with an individual physician, and so I prescribe these all myself.
Okay.
There are a few companies out there that they still have to be prescribed in the United States. I guess in Europe you don't need to have them prescribed, you can get one. But in the US, then you'd have to work with one of the companies that is going to have you do a medical provider evaluation, a telemedicine visit, essentially what we do, and then they can prescribe it. My approach is a little bit more hands-on. Most of the CGM companies are kind of protocol driven and algorithm driven. Whereas, I'm still kind of like, I want my health coach to call you a couple times a month,
Yeah.
and I want to do a visit with you once a month. So we take that approach. Regarding costs, because people might be interested in this, you can usually get an initial CGM. I use the Freestyle Libre from Abbott. And you can usually get an initial CGM if you haven't had one before with a coupon. So you can get one for the trial at no cost. We supply them to all our patients at no cost. And then subsequent to that, it's a little bit tricky. But what I have found is that if you have insurance coverage, and generally I'm talking private insurance company or some Medicare Advantage plans, usually that will knock down the cost. So, again, I use them diagnostically for a couple of weeks, but then a lot of patients, they want them to guide diet long term. And they can usually get a CGM for about $30 for a 2 week period of time.
Okay.
So it knocks the cost down in a little bit more than half if you have private insurance company. So it's interesting. You don't have to be pre-diabetic. You don't have to be diabetic. It's just if you have certain coverage, generally the contracted rate for the CGM to get it in your hands is about a $30 code.
Good to know, because a lot of times you have to have a diabetes diagnosis to get anywhere or get a prescription. So yeah, $30 is very affordable compared to, I mean, it's usually a couple $100, or I know I work with a company where you can get them for 75, but that $30, that's well worth it. Well worth the 2 weeks of data that you're gonna
Well,
collect.
and balance that. I know it's hard to predict what your health is going to be like down the road, but balance that against potential healthcare costs. When I have patients that we completely reverse their pre-diabetes, so they're never going to go on to be diabetic and have to pay for those medications or the complications of those medications. It's an investment, and I think it's well worth it. And quite honestly, that's why I wrote the book, because CGMs have been out there for 15 years for diabetics. But really, an important intervention is that pre-diabetic period. Our healthcare system is set up. I don't mean to go on here too long, but it's set up for disease management. You go in and you see your doc for 20 minutes once or twice a year. It's not set up to intervene in this manner. And so getting the CGM on and really understanding how you have the power to control your health, I think, is a big deal.
Amen. Yes, I couldn't agree more. So yeah, thanks again for all the work that you're doing, and for your book. I would definitely encourage everybody to grab that as a resource. And not only does it go over CGMs, it goes over metabolic health and how to get started with reversing the disease process and making your metabolic health markers better. So go grab that for sure. And thanks for all the work that you're doing. And I hope you continue with it for a long time.
Thank you very much.